I'm Dr. Douglas Galasco. I'm a neurologist and a professor in the Department of Neurosciences at University of California, San Diego. I see patients at the Memory Disorders Clinic at UCSD, and I'm involved in research at the Shirley Marcos Alzheimer's Disease Research Center. The screening process can include testing a patient if, for example, they happen to be in the office on their own, or it may involve, in the ideal situation, testing the patient and also being able to ask questions of an informant who knows them very well. As I mentioned before, patients who have memory loss are often unable to give an adequate history of exactly how their memory loss is impacting on them. And secondly, in the early stages of Alzheimer's disease, there may be a degree of denial of symptoms. To evaluate instruments, we did a literature review based on a survey of publications available in PubMed. We also wanted to come up with instruments that would be relatively brief, well-known, and if possible, would have translated versions or would be easy to translate, particularly into Spanish. We also wanted to have instruments where there were cutoffs available from studies across diverse practices. Let's talk now about the various screening instruments. We recommended the Mini-Cog, which is a brief test of remembering 3 words and drawing a clock. We considered a number of instruments, including the Mini-Mental State Exam, which has been widely used and would be known to many physicians. There were several reasons for our choice. The Mini-Cog is easier and shorter to administer than the Mini-Mental, for example. There are translations of the Mini-Cog available in Spanish that are relatively straightforward to administer. And finally, the Mini-Mental is associated with the need for payment. The publisher who originally published the first paper on the Mini-Mental, together with the authors of the Mini-Mental, a few years ago executed a copyright agreement, and in principle, anyone who uses the Mini-Mental is supposed to pay $1 to the publishers every single time that they use it. The question of how to find out about a patient's functional abilities can be challenging and sometimes a little sensitive and delicate. In an optimal situation, it can be helpful to interview the informant in a separate room from the patient. If you have this resource or option available, I would recommend it. If it's not available and the patient and informant are interviewed together, there are some strategies that one can use. One thing I sometimes do is to ask the patient how they think they're doing with regards to activities such as managing medications, remembering appointments and plans, and conducting their daily affairs and activities, and whether they think they're having any problems. If I'm concerned about a patient and they say everything is fine, they're having no problems at all, I'll simply say to the informant, well, I'd like to get a little more information or a second opinion about some specific aspects in this area. And I might ask the informant, do you think that the person repeats conversations sometimes, sometimes has a little more trouble than you'd expect with remembering appointments and plans? Is there any particular episode you can think of that made you concerned in the last month or two? So one can do this in a structured or unstructured format. For physicians who lack a certain amount of, who might be pressed for time or might not think of individualized questions to ask, an instrument such as the AD8 is an excellent resource. This consists of a series of 8 questions in which people are asked about whether there have been changes over the last year or two in abilities to make decisions, for example, about finances, whether they still have as much interest in hobbies and activities, whether they repeat things over and over again, and a number of other questions. The 88 can be completed by an informant who is waiting in the office, for example, and the questionnaire could also be administered by a member of the clinic staff. It doesn't necessarily have to be administered by the physician. We looked at instruments that assess depression, and after much discussion, decided that the PHQ-2 was a very reasonable entree into whether there are significant major depressive symptoms that might be impacting cognition or not. So if the answer to both of the questions on the PHQ-2 is no, not at all, then it's reasonable to conclude that major depression is not the primary cause of changes in cognition. Now we will show you some examples of screening techniques that a physician might want to use.
Well, welcome to your visit today, June. I see you're here with your husband, and how have you been since I last saw you? Everything okay?
I've been fine.
Yeah, you're just here for a routine visit today, and nothing unusual going on?
No, but thought it'd be good to be here with me.
Okay, great. And Bud, is everything okay at home with June?
Yeah, I think so. But I have noticed that she sometimes will say the same thing, a few minutes after she's just said the same thing.
Okay. Does she ever have any trouble finding the right word to say or anything of that nature?
Yeah, she does, but I think that's true of myself as well as our contemporaries.
It's pretty mild,
yeah,
if it is there at all.
It's not more than usual, I don't think. Do you think?
I'm not really sure even what he's...
Okay. And do you ever notice June to have confusion? Not know where she is or be disoriented or anything of that nature?
Directions are a problem sometimes.
Okay. How about misplacing things and not finding things?
Oh, yeah.
And are you feeling at all down or sad or depressed? Anything like that going on?
No, I try to keep busy, and I push myself to get to bed a little earlier than normal. I think that I've read that it's important to have sleep, and I'm used to sleeping maybe 5 hours, but now I'm pushing myself to sleep about 7 hours.
Okay. 5, well, that's not very much.
No, that's what I've been reading.
Yeah.
I thought it was a good thing, to not have a lot of sleep, but they say no, as you get older, it's better to have more sleep.
Well, what I'd like to do is a little screening test. It'll only take a couple minutes to just test your memory a little bit. Okay?
You're going to test his too?
Well, we might come back to that later. Yes, we could. Okay, so please listen carefully. I am going to say 3 words that I want you to repeat back to me now and try to remember.
Okay.
The 3 words are banana, sunrise, chair.
Oh, you want me to say banana, sunrise, and chair.
Excellent. Next, I want you to draw a clock for me. So I'm going to give you a sheet of paper and a pen. And I want you to put all the numbers in the clock. First, put the numbers where they're supposed to go. Now set the hands to 10 past 11. What were the 3 words I asked you to remember?
Oh, we had banana, chair, and sunrise.
Very good. So you scored a 5-pointer out of 5 points.
Oh.
So that's very good. And I'm delighted about that because I think that today I would be ready to just give you some reassurance that I think even though you might have noted some mild cognitive changes, I think that your test was pretty normal, and I just want to reassure you. But I think what we should do is maybe test you again in 6 to 12 months, or if you were to notice more problem, Bud, as time would go by, or you started, June, to notice some problems, then I'd want you to call and come back and we'll test you sooner. But right now, I don't think there's much more to do or be concerned about it. Okay?
Good.
So June did really well on her mini-cog test. She got 5 out of 5 points, as you saw. But on the AD8, which is screening for dementia, she didn't do as well as I would have hoped. So there's some indication here that what Bud is talking about may be something we should pay attention to. And June, classically, is a classic patient that doesn't really remember, that she forgets. So it's possible that June is suffering from mild cognitive impairment, not really achieving the level of dementia or Alzheimer's disease, but it could be that she requires a little bit more closer surveillance. So I'm going to recommend to her that she come back in 6 months, no more than a year, and if things continue to develop along this line, I'll want to evaluate her fully.